So, a very warm hello to all of you. I'm Dr. Tushar Mehta. I'm an orthopedic surgeon and a faculty of orthopedics. Well, today, this video that you are watching right now is to teach you, is to guide you what to do if you've got a great rank in NEET-PG 25 and if you are really interested in finding answers to your questions that radiology, should I pick it, should I not? I have the pleasure of having Dr. Gaurav Vashisht with me, who is an MD radiology from DMC Ludhiana. After that, he's done his fellowship in musculoskeletal imaging and interventions from Mumbai, another visiting fellowship in pediatric musculoskeletal ultrasound from Germany. Well, not only he has been my student, but he has been a colleague, and to tell you all, he has been my doctor as well. So the interventional radiology part of Dr. Gaurav is a blessing for most of the people living in the Millennium City, Gurugram, and of course, people around Gurugram. And I'm one of the beneficiaries. Welcome, Dr. Gaurav.
Thank you so much, Dr. Tushar, for having me here. And it's a great pleasure for me to come on this platform, not only for guiding people around, but for hosting me. And you're such a great mentor. So I studied orthopedics with you in 2012, and it's 2025 now. And it's a small world that even after 13 years, we are connected in some way or the other.
Yes. So, few quick questions.
So I always wanted a comfortable lifestyle for myself, or I always wanted that I should have time for me, my family, and to roam around different places. I wanted to explore different kinds of, areas around the world, though I haven't traveled much. But still, one thing was lifestyle and work-life balance. And I was always a medicine guy. I always wanted to take medicine. But because we did not have that much exposure of radiological investigations back then, like people have now. But when I got a good rank, then I took MD radiology, and that was the only one great thing which I had in my mind was work-life balance, along with you're integrating imaging with medicine. So when I got that opportunity to take the seat, so that was the only concern that yes, I can utilize imaging in medicine, and not only medicine, apart from that, be it orthopedics, pediatrics, OB/GYN, and every other specialty is allied with radiology. So it's a subspecialized, super specialized branch now altogether. It's called clinical radiology, not only diagnostic radiology, because we deal both with diagnosis and interventions.
Nice. So you said one thing that I was always a medicine guy. Now I have a question. I'll tell you. There are thousands of doctors who finish their MBBS, and during that process, they live with this one feeling that I'm a medicine guy. Not only they feel they're medicine guy, they're obsessed with medicine. But the moment they get a good rank, a great rank, people surrounding them, and even some people in the education network, they start telling them that no, there's nothing in medicine, you should take radiology. What's your take on that?
So I think if you're that much passionate about a particular branch, that you just want to do medicine and you want to super specialize, or you don't want to super specialize in any of the allied branches like pulmonology or cardiology or rheumatology. So if you are that much passionate and you feel that you cannot do anything but this, you should definitely listen to your heart, not others, and go with your gut feeling, because that is what will make you eventually happy. The branch is going to stay with you for life. The college, your friends, your relatives, your neighbors, they're not going to accompany you for the rest of your professional life. So what comes
Definitely.
from within should be taken forward. Yes, if you need guidance, you should definitely consult your seniors and your contemporaries. But if you feel that you are not satisfied with something, and there's something, which is coming up from your heart that no, I'm not taking a right decision, don't go for it. Always listen to your heart and discuss and then move ahead.
So the message is very clear to everybody who's watching right now that if you are always passionate about medicine, but you got a good rank and now everybody is telling you, no, change it. Please change the people who are asking you to change it, because there is no point in going towards something which you have never liked or probably never aspired for, but now you got a good rank, so you think कि नहीं मुझे तो अब रेडियोलॉजी करना है क्योंकि मेरा रैंक अच्छा आ गया और अच्छे रैंक पे रेडियोलॉजी करना है. So for last few years what we are seeing is कि ठीक है रेडियोलॉजी टॉपर्स लेते हैं but मेडिसिन भी टॉपर्स लेते हैं, तो ऐसा कुछ भी नहीं है. So there is no hard and fast rule. So listen to your gut, to your heart, and take the call. Dr. Gaurav, I have one more question. Second question, to be honest, what is your take on radiology of today, of 25?
So it's an amazing branch. And as a like for me, I would say taking up radiology was a blessing. And initially, I really had doubts even after joining the branch for at least 2 months. I joined in the first counseling itself. And but when the subsequent counselings were going on, we had that option to, attend the later phase of the counseling as well. But I had a strong feeling in my mind that I should just, change it. I think this is the branch which I have never thought of taking it. And I wasn't liking it in the initial 1 or 2 weeks. But gradually, a senior of mine, he guided me well. And he told me just wait for a month, do not change it, and you will really love it because he was my SR and senior resident that time. And she really guided me up. So in the sense that do not leave the branch, just listen and move on because the seniors they guide you as to what is because you
Yes,
never
definitely.
see radiology during your UG days. And
Hmm.
once you come in and first year for every branch, I would say, be it surgery, be it orthopedics, be it pediatrics, be it medicine, every branch you're going to hate it during the first few days or few months. And you will feel like running away. Why did I join this? I never thought of that I will join PG and I will have to face these. So it's true for all the branch, I think. Because I had my friends in all the other branches, and the only good thing they used to say, "Yeah, तुम लोग तो सो के आते हो, हम तो सोते भी नहीं हैं." So we used to have, yeah, we have something extra with
Yes, that's the usual thing which other branches people tell to radiology people. So there's one query, the third question. बहुत सारे जो लोग मेडिसिन के लिए पैशनेट होते हैं, when they go towards radiology, they try to go towards radiology because everybody is saying, but for radiology, they have this feeling that it is a little costly, rather very much costly. So what do you think is how much is this easy and how much is this tough to have an individual setup? And to have an individual setup, is that really necessary?
So, firstly, 2 points in this. To have an individual setup or to work in an institution or to do just as a job in a private diagnostic center, there are three options. So people who prefer working in the institutional setup where they have, they end up doing senior residency and they are promoted as consultants, then they have that leverage of having residents with them where they can have lifelong learning, active learning. Then you have thesis and all. Apart from that, when you are in a government or a private setup in the institution, you have other advantages in terms of multidisciplinary teams, the meetings which happen, and then you overall evolve. In terms of finances, that is definitely less on the lesser scale, but it is a stable kind, and then it gradually increases as you are promoted to the senior consultant level. In the private setting, when you are in a private hospital, the corporate hospitals, things are again different from the institutional setups in the government. So here again your hierarchy increases and definitely you see a different kind of spectrum. You have more sophisticated machinery because the corporate hospitals invest in heavy machinery and your learning is that way. Okay.
Hmm.
And when you are into a private setup as a radiologist who is working in a job, then again you have access to all the good modalities like ultrasound, MRI, CT scan. And in this era of 25, everyone has, access to great MRI machines and everyone wants to do the highest of the work. So you tend to work with best of the machines with the best of the timings which you wish to have, be it 9 to 6, be it 9 to 5, 9 to 1, 10 to 2, whatever you wish to. 4 hours, 6 hours, 8 hours, 10 hours, 12 hours, 15 hours. There are people who work like that. So it's up to you how you want to work. And then you have your own setup where you have to establish, you need to put in your own machinery. Definitely, it's an expensive job. Expensive in the sense that you have to invest a basic, something, and then, the cost has to be completed in a few years that whatever you have invested. So initially, few years, some people start from the very beginning who have that clear set of mind. We have done with our MD, and now we are putting up our center. We start with doing our ultrasounds and CTs, or just doing ultrasounds and X-rays, or just doing ultrasounds, and that's it. There are some people who wish to progress further up, that I want to excel my skills, more improve my cross-sectional skills, either into a particular branch, like I specialized in musculoskeletal radiology. And there are some certain people who specialize in pediatric radiology. Some do it like OBGYN, fetal radiology, and some do
Hmm.
neuroradiology. And then there is vascular intervention. Okay, so it's all like a different scenario now in 25. So that way one can, move ahead further. So putting up your own center is again not a bad option. But then once you have an experience of what you're doing, so it's always better that you can give to the society, because ultimately, as radiologist, as imaging specialist, you are not just giving a
Mm.
report. You are signing that report as an authority as to how that patient will be treated further.
Yes,
And
definitely.
it means a lot. Apart from that, you have an access to non-vascular interventions like aspirations, FNACs, biopsies, management stuff like, ultrasound guided pain management injections. Then you have ultrasound guided PICC line placements for cancer patients, and a lot of things are there which can be done. So, along with diagnostic, you are
Mm.
doing intervention, you are treating your patient, and you are guiding that patient to take an opinion from a specialized doctor further as to which doctor
Mm.
you should actually go. And that makes a difference where you are just a basic radiologist or you are a specialized radiologist. So,
Mm.
all these setups are there, and there are people who wish to work better in the government setup because you have access to more patients, you have access to more research. Then the private setups are there where you have corporate hospitals and diagnostic centers. And definitely the expenditure of putting your own setup is little more, but if someone can, one can gradually put up.
All right, nicely summed up. So तीन ऑप्शन है, आप गवर्नमेंट सेटअप में जाइए, आप प्राइवेट हॉस्पिटल में जॉब करिए, आप अपना सेटअप लगाइए. अब जो तीसरी वाली चीज है,
One
दैट
thing
इज
more I would
समथिंग.
say.
या.
So there are people who wish to go abroad as well after doing radiology from India. So you have access to FRCR, which is a Fellow of Royal College of Radiologists. So it's based out in London, Singapore, where people can go and work later on. You can get absorbed in like NHS in the UK, and people go to National University of Singapore, NUS in Singapore, and FRANZER in Australia and New Zealand. So people can give their exam after this and get licensed and work at different places as well. US is a difficult situation, difficult country to get established as a radiologist, because after giving all the steps, you need to do a complete residency there again, which is again for 5 years, and then a fellowship to get into the system. And getting diagnostic radiology is a very tough job unless you have worked there for like under the research section. So there are different clauses for that, sir.
ओके, सो मैं उसी बात पे आता हूँ. तो गवर्नमेंट सेटअप, वर्किंग फॉर अ प्राइवेट कॉर्पोरेट सेटअप एंड ओनिंग योर ओन सेटअप. सो आज की डेट में ना, द यंगर जनरेशन जो है वो थोड़ी चेंज हो चुकी है. और वो चेंज इसलिए हो चुकी है क्योंकि वो ये दो ही सवाल पूछती है: कितना पैसा मिलेगा, कितना पैसा लगाना पड़ेगा. हाउ
Ah,
मच इज द सेटअप कॉस्ट, एंड हाउ मच विल आई अर्न, एंड हाउ सून विल आई अर्न. सो मेरे कुछ सवाल है. व्हाट इज द वन वर्ड में इसको आंसर करना है. व्हाट इज द वन लाइन में, व्हाट इज द स्टार्टिंग सैलरी ऑफ अ रेडियोलॉजिस्ट इमीडिएटली इन अ टियर 1 सिटी? यू फिनिश एमडी रेडियो, you start your job in a corporate setup. What is the starting salary?
so around 2.5 to 3 lakhs.
2.5 to 3 lakhs. If I have to start my own setup, what is the cost of an X-ray machine?
Around 15 to 20 lakhs. And
New machine. What is the cost of an ultrasound machine?
so it ranges from 15 lakhs and it can go till 1 CR.
So, what is probably the cost of a machine on which I can do the obs and gynae stuff and the basic stuff?
So basic around 30 to 40 lakhs.
30 to 40 lakhs. What is the cost of a CT scan machine?
So again, it ranges from a 4 slice CT to a 16 slice CT to a 32 slice to 128 slice again.
एक
But
एक एक
the
एक
basic, if I
rough
say,
average.
so from 1.5 to 4.5 CR.
1.5 to 4.5 CR. Roughly, we take the average of 2.5 CR or maybe 3 CR. What is the cost of an MRI machine?
Yeah, again, a 1.5 Tesla would be like around 4.5 approximately.
4.5 CR.
CR, and
And three
would
Tesla?
go till 8 to 10 CR.
3 Tesla would go around 8 to 10 CR. सो बहुत से लोग डेली मैसेजेस आते हैं, सर एमडी रेडियो करना है और अपना सेटअप. एंड आई एम श्योर दैट फ्रॉम दिस वीडियो विल कट दिस क्लिप and we'll put it out on Instagram so that people get to know that what is the cost of owning a setup, and that is from the Dr. Gaurav's mouth only. So now you get the exact value because people give you different values. So now you know because he's the actual guy who's working in the setup. Dr. Gaurav, my fourth question to you: what is your take on the the elephant in the room, AI in radiology?
So I think
तो
AI
एक आप, हाँ, अब आपको एक तो ये बताना है कि एआई इन रेडियोलॉजी का क्या.
रेडियोलॉजी को भी खा जाएगा.
वो तो बोलते हैं ऑर्थोपेडिक्स और सर्जरी को भी कहा जाएगा एक दिन.
I mean, I was never a very tech savvy person in terms of, artificial intelligence. But off late, when I started, looking at these apps, it really helped me out to increase my speed of my reporting and gave me good quality, more time. At least, if I used to take 1 hour to complete 4 scans or 5 scans. So I complete that in 30 minutes now. So there are automated AI built dictation softwares, and there are different platforms which have come up where you just tell like 5 words and the report is made up, and you can just copy paste it and everything. But if you just do that, you're gonna land up in trouble because AI will give you a lot of things. There are similar multiple patterns for a similar disease, or I would say the opposite. There are multiple patterns or a singular pattern for a different disease. So I'll give you an example. So there was a patient of 1 year old MRI brain which came up to me yesterday. It had a frontoparietal region. It was like an encephalitis kind of a picture because the history provided was fever and seizures. Okay. And based on that, we labeled that as a meningoencephalitis. Okay. And after a few hours, the pediatrician called me up and he said that the child has hemiplegia on the left side. Like, but the history provided was fever by your junior resident, the person who came up for the scan. So it was done in a diagnostic center. The doctor who was accompanying the child never gave us this history that he had deviation of face. And then that's an infarct. And I told him that the initial picture did not look like. So if I entered all those findings in my AI software, it gave me the first impression as a meningoencephalitis. Okay, with infarct. Then he said it's a focal cortical dysplasia because the child had seizures also, and he gave 4 or 5 more differentials. But unless we make use of the clinical picture in terms of with synchronizing with the imaging, we will make wrong decisions, we will make wrong impressions, and that will go with your signature and brand name. So do not blindly trust AI, use it judiciously. And if you don't use it, you will be replaced. Okay, so that is important. Use these because you have to go with the trend, how it's functioning. And ultimately, we labeled that as a vasculitic infarct for this case because the child had tetralogy of Fallot. Okay, and associated, we could see that, the vessels in the supraclavicular ICA, they were all narrowed. And it was a Moya spectrum of disease, which so that was a vasculopathic related infarct, but not meningoencephalitis because fever tha hi nahi usko. So it was a wrong history group. So it's important to be in synchrony with the clinician, know the details, why we are doing the scan, what we are looking for, and discuss. And that makes our job easier with AI. So AI is not going to replace it, according to me. And it's of great help even when I'm at the airport going for a conference, I have my dictation tools with me. I can report it there. Even if I have to leave from the center early, I can dictate it anywhere. So that,
So I always, sorry, you were saying
I think
something.
that's the good use of the technology, but not to get dependent on that.
Yeah.
If your internet speed is not coming, you are not going to get access to that. You have to use it.
Yes. So I always give an example कि पिछले कुछ सालों में we all are very much addicted to the GPS, the Google Maps.
Yeah.
So especially in tier 1 cities where the traffic is unpredictable, suddenly you know the road, आपको सड़क पता है, आपको रूट पता है, आपको सब पता है, but suddenly आपको पता नहीं है कि जिस रोड से आप रोज जाते हो वहाँ जाम लग जाएगा, so you take alternative route. So we are addicted to Google Maps, but at the same time, I can't be addicted to a driverless car which Tesla has made. So as we speak today, Tesla just took a place to start selling their cars in Delhi NCR and in Mumbai. But Tesla has got the technology. I am totally supportive of that. But उस टेक्नोलॉजी को ये तो नहीं पता ना कि हिंदुस्तान की सड़कें कितनी प्यारी हैं कि जहां पर suddenly auntie will cross and will say रोको because I am crossing, and suddenly you will see a cow coming in the front and suddenly a bike wala will go from there. So we can use Google Maps, but at the same time we are very mindful कि we can't leave everything to a self-driven car कि ये तो बस मुझे पहुंचा ही देगी. So ऐसा नहीं. So AI, probably Dr. Gaurav has given the best description that AI will not replace radiology. It will replace the radiologist who will never learn how to use AI in radiology. And this हर कुछ टाइम में एक पैराडाइम शिफ्ट आता है, कोई नई चीज आती है और लोग उसको अडेप्ट करते हैं और धीरे धीरे फिर आगे बढ़ते हैं. Dr. Gaurav, my next question to you, and I'm asking you particularly that interventional radiology, and why I'm asking is because I've seen you for such a long time now, and you're doing amazing work. So interventional radiology में क्या हो रहा है, क्या चल रहा है, क्या होगा, क्या हो सकता है? I'll tell you why मैं क्वेश्चन क्यों पूछ रहा हूँ. बहुत लोग में कहीं ना कहीं एक पीछे एक सर्जिकल बेंट ऑफ माइंड होता है, तो वो उनको लगता है कि मैं हूं तो वही वाला, लेकिन मैं उतना कि मैं फ्रैक्चर ठीक कर रहा हूँ या मैं गॉल ब्लैडर निकाल रहा हूँ या मैं क्रेनियोटमी करके खड़ा हूँ, ले तो मैं रेडियोलॉजी रहा हूँ, मेरी रैंक अच्छी है, लेकिन दिल से मैं सर्जन हूँ। और उसको एक तो इंटरवेंशनल रेडियोलॉजी है क्या, उसमें आजकल चल क्या रहा है, उसमें सबसे ज्यादा पैसा किसमें है, कामयाबी किसमें है, आप क्या कर रहे हो, ये क्वेश्चंस के आंसर आपको देने हैं। और मैं इसलिए भी बोलूंगा लास्ट थिंग, बिकॉज बहुत से रेडियोलॉजिस्ट इसके बारे में बात कर रहे हैं, डिस्पाइट द फैक्ट दैट दे आर नॉट डूइंग इट, बट स्टिल दे आर टॉकिंग अबाउट इट। तो आप कर रहे हो तो आप बताइए।
Which is the bread and butter for a radiologist. And ultrasound is something which is skill dependent, an operator dependent thing. Even if there are AI operated softwares which come up in different machines, you get help out of them. Come up usually practiced in bigger hospital setups where there are critical patients. So when I was back then in residency, we had an opportunity to work for 6 months in IR, and we did a lot of vascular stuff with our boss. Okay, and there are procedures like TIPS, which is the used in patients with cirrhosis and portal hypertension.
यस।
So TIPS is one which people do in vascular radiology. Then there is coiling and stenting. Okay, coiling means like if there is a pseudoaneurysm and there's a bleeding going on, active extravasation of blood is happening in the body. One can go in a non-invasive way, puncture the femoral or radial arteries, go in and kind of coil and clip that area and come out. So then there are options like there are like gel foam embolizations, where again you can go in through the vessels through placing different catheters. You can inject, block that area, and come out. Then vascular malformations. You have access to doing sclerotherapy and polydocanol, and then then you have treatment for various tumors like the hepatocellular carcinoma. So you have radiofrequency ablation, which is called RFA, and then we have TACE, which is transarterial chemoembolization, transarterial radioembolization. So all these procedures are being done by the intervention radiology people. Okay, and you get great satisfaction in treating such patients. Okay, other is then you have the cryotherapy. Then you have RFAs for renal cell carcinomas, for focal metastasis. So people prefer to go in a non-surgical way where you're not cut up completely, but with just one incision, you are going in, not even a big incision, just a one puncture, and you are getting treated. And you can go home after a day without having. Then varicose veins, people do a lot of RF ablations again, laser treatments for varicose veins. Apart from that, there are a bunch of non-vascular interventions like drainage of the ascitic fluid, pleural fluid, and all these fluids can be sent to the pathologist for chemical evaluation. Then you have FNACs, image-guided biopsies, which can be done with ultrasound as well as CT, and bone biopsies, lung biopsies, deep tumors, a lot of areas which can be targeted. And then you have placement of pigtail catheters for abscess drainage. There is a liver abscess which needs surgical excision removal, but then you can just do wonders by using your ultrasound, put a needle, put the wire, put the catheter, and just connect it with the Eurobag. And you see the pus coming out. You feel so happy that you're treating a patient there.
Yes.
Have different post-surgical complications, get a lot of abdominal collections, and you can always send someone's pus culture for sensitivity. You are draining your psoas abscesses in tubercular spondylodiscitis patients. So a lot of things come up, and along with that, in musculoskeletal radiology, what we practice is pain management, and eventually, I mean, in all the joints of the body, be it elbow, shoulder, wrist, hip, knee, ankle, everywhere, you can do a lot of interventions for pain relief as well as spine, where you can do transforaminal blocks, epidurals, and facet joints, pars interarticularis, a lot of stuff, and not the least bone biopsies. It's a huge scope, and most of the people do, like I don't do vascular radiology, vascular interventions, because it needs a bigger setup and a different approach too. But even if you do non-vascular, you feel contented.
So, Dr. Gaurav, yeah, हम इसको आगे लेके चलते हैं. I want to build on this idea. Why I'm asking this, because students ask me, sir, मैं radiology ले रहा हूँ. I don't want to go to the conventional path. I don't want to earn 2.5, 3 lakhs in a tier 1 or a tier 2 city in the beginning of my career. Honestly, sir, I don't see any logic in making a setup of my own, because setting up an X-ray machine, I mean, every orthopedic surgeon has his own X-ray machine. Most of them have, I think. And ultrasound is again a challenge. CT is a challenge. MRI is a challenge because of the ultrasound, because PCP and DT issues. Now even MBBS students are aware of it. CT, MRI is too costly. So they are into intervention, but they don't know. So what you have told is amazing. That's a gold mine for them. But यहाँ से क्वेश्चन ये आता है कि सर पेशेंट मेरे पास क्यों आएगा? अगर पेशेंट को एबीएम है तो वो न्यूरो सर्जन के पास जाएगा, पेशेंट को जॉइंट का इशू है तो वो ऑर्थोपेडिक सर्जन के पास जाएगा। तो वहां से ऑर्थोपेडिक सर्जन या न्यूरो सर्जन या वैस्कुलर सर्जन एक ऑप्शन देगा कि अगर आपको मिनिमल इन्वेजिव करना है या आपको विदाउट इंसिजन करना है तो आप रेडियोलॉजिस्ट के पास जाइए और वहां जाके इंटरवेंशनल रेडियोलॉजी से करा लीजिए। तो सर ये तो डिपेंडेंट हो। फिर दूसरा क्वेश्चन उनका आता, तो मैं बोलता हूँ कि हाँ थोड़ा अभी भी इंट्रा आर्टिकुलर इंजेक्शंस में, बट नाउ फॉर द बेटरमेंट ऑफ माय पेशेंट आई हैव अ पर्सनल फीलिंग that Dr. Gaurav should inject because he will do it with far more sensitivity, specificity and precision that what I can do blindly without an ultrasound machine. तो डॉक्टर गौरव, आपको लगता है कि आज अगर एक लड़का सिर्फ इस उम्मीद में इंटरवेंशनल रेडियोलॉजी की उम्मीद में अगर रेडियोलॉजी उठाता है, तो क्या वो अगले 5 साल में 7 साल में जब वो मार्केट में आएगा तो उस वक्त तक इंटरवेंशनल रेडियोलॉजी में रेडियोलॉजिस्ट विल बी द पोस्टर बॉय ऑफ अ सेंटर ऑफ अ हॉस्पिटल?
So people who practice interventions, they have started with their own clinics where they evaluate the patient themselves and they give their basic treatment, which can be done in a conservative way without any interventions. And if it doesn't improve, you can always offer them the minimally invasive interventions, which can help out. And if you feel truthfully that this is a way where we can help this patient out, go ahead. If you feel that doing this will not really help him, he should send that to the concerned department where he can get a definitive treatment done.
Yeah.
Many people in the
So
country.
that is the point I want to mention today, that Dr. Gaurav has clearly mentioned that even if you are a radiologist, after interventional radiology, you can open your own setup. People have already started opening up setups. He's a young guy and he's telling you that, and he's telling you, kya I am telling you because I am associated with him for such a long time now. And I'm telling you that after interventional radiology, you can have your own, forget about a clinic, you can have your own setup where you can have all the modalities together, not only for diagnostic, but for therapeutic purpose. So today, if a radiologist, any age and stage in life, who does not think that radiology can be interventional, or even if it is interventional, it will be dependent on certain set of doctors. It's not like that. जब गैस्ट्रोएंट्रोलॉजी, मेडिकल गैस्ट्रोएंट्रोलॉजी, डायग्नोस्टिक से थेरेपेटिक, बड़े बड़े गैस्ट्रो सर्जन्स भी डिनाइल में दिए थे कि नहीं ये नहीं हो सकता, आप ये नहीं कर सकते। लेकिन फिर दुनिया भर की चीज दे आर इन, they have not exposure, they have not got any exposure to that thing. But today you need to understand that you're listening from his own mouth that कि आज की डेट में आपका अपना एक सेटअप हो सकता है। जरूरी नहीं है कि आप उसे हैवी कैपिटल लोडेड बनाएं और आप उसमें करोड़ों रुपए की मशीन, कितना पैसा।
बात जिसने काम करना स्टार्ट किया, जिसने ये मार्केट पे ये सब बना दिया कि 50 रुपए में हम 10 रुपए में एक्सरे रिपोर्ट कर देंगे, 100 रुपए में सीटी रिपोर्ट कर देंगे और 200 रुपए में एमआरआई रिपोर्ट कर देंगे, तो क्वालिटी ऑफ द रिपोर्ट ऑल्सो गोज। वाई? बिकॉज पीपल वर्क विथ फॉर वॉल्यूम्स। कि अगर मैंने 100
ओके।
स्कैन रिपोर्ट किए 200 रुपए के हिसाब से, तो मैंने दिन का 20,000 रुपए कमा लिया। उसकी लाइफ में वही सेटिस्फैक्शन का एक लेवल है। बट
ओके।
उसने जो स्कैन रिपोर्ट की। सो इन माय प्रैक्टिस व्हाट आई हैव डन, I have always asked people who have approached me for a teleradiology thing. I don't ask for the rates first. I ask for the images. Okay. Because
क्वालिटी ओवर क्वांटिटी।
correct. So even if I report 5 cases in a day from teleradiology, I would want that they are best of the images done with my protocol, and I will ask money what I deserve to get. 150 rupees. I can work for free also. I have worked many years doing free opinions and doing free reportings for radiographs for charitable people. I still do it, but I get a sense of happiness by doing that because मेरे को image quality अच्छी दिखती है and I learn. Every day is a new learning for me, and radiology is such a branch that you cannot be perfect एनी टाइम। आज भी मैं नई चीज सीख रहा था और आज एक मैं ऑर्थोपेडिक सर्जन से डिस्कस कर रहा था। ही सेड मैंने कभी नहीं सुना यार ये, बिकॉज किसी की रिपोर्ट के अंदर उसमें एसीएल टेयर था 12 साल के बच्चे का। मैंने बोला नहीं, ये एसीएल इसका है ही नहीं, बना ही नहीं हुआ है। सो ही सेड कि ऐसा कैसे हो सकता है। And then we had a discussion and then we shared articles and all those things. And then I learned a few things from him because he sent me the clinical pictures कि कैसे उसके बिना laxity था बच्चे का। And parents कहते कि इसको कभी चोट लगी नहीं है तो meniscal tears और ACL कैसे जा सकता है दोनों, और उसको दोनों knees में ऐसा है, not even one. और for the teleradiology thing, if someone plans to do it in the future, it's a huge scope, but do not compromise with the quality. There are people in my city, in different hospitals, the smaller hospitals who have CT access. They get reporting done at 100 rupees, 150 rupees, 200 rupees. and they get such reports
Hmm.
that they have to again get it done by their in-house radiologist next morning. Ultimate loser is the patient. If a patient has mesenteric
Hmm.
ischemia and you miss that, the patient is not going to survive. He's not going to see the next light in the light coming morning. So
Hmm.
it's a huge
Hmm.
responsibility
Hmm.
for a radiologist to work in appropriate conditions as one has got trained in
Hmm.
residency, and don't
Hmm.
lose that focus ever, because people
Hmm.
spend money to get a diagnosis, and once you don't get a diagnosis, you're not getting adequate treatment.
Hmm.
That every day we also make mistakes, other people also make mistakes, everyone, there's no one who is perfect, but we all learn from our mistakes, and that's the thing one should carry forward, that the next day has to be better than yesterday.
Better than the previous day. Absolutely. So, thank you, Dr. Gaurav. Of course, I won't take much of your time now, and thank you so much for these amazing inputs that you have given. You have answered precisely all the questions that every successive year, whenever the NEET PG results are out, people have in their mind, and they get guided by certain people who are actually not doing what they are supposed to do right now. And वहाँ पे बहुत confusion हो जाता है क्योंकि बच्चे वो क्या होगा और बता वो रहे हैं
I
तो
think
अच्छा लगा मुझे
radiology is a absolutely wonderful branch. I enjoy it every day, learning with new cases. You get challenges in every, like at least one or two cases are pretty challenging every day.
हम्म
And you have to, look for कि
keep
क्या
scratching your gray matter for this
Yeah,
क्या रहा है
and
ये
it's
क्या
like
रहा है
if you don't use your brain and if you just use AI,
देखने में
अपना
सुन रहा
दिमाग
है
को ही चलाना है, and you can always make the best use of technology, move ahead. And I think जिसको रेडियोलॉजी मिलती है उसको जरूर लेनी चाहिए, जिसका take a call. Radiology is a wonderful branch. I said I have no regrets with that, and I happily practice, as you know. So if you have an opportunity to get radiology, and you have interest in diagnostic as well as you want to perform interventions, you can treat your patients that way. Definitely go for that branch. Radiology is a blessing. Like other branches, every branch has its own plus and minus. There's no perfection or 100% perfection for any branch, be it anesthesiology, be it medicine, be it radiology, be it physiology. People love doing physiology and anatomy also. I know people who have done anatomy and then they've become embryologist and they are running IVF centers. So, I mean, every branch has its own charm. Do what you feel like, discuss with your parents, discuss with your seniors, and then take a decision. And I think life will be glorious. Thank you, and all the best to each one of you who is listening to this.
तो आज हम सबको ये समझ में आया कि रेडियोलॉजी के बारे में जो एक परसेप्शन है कि एक बंद कमरे में बिना पेशेंट इंटरेक्शन के एक ऐसी ब्रांच में करना जिसमें आपका दिन और आपकी जिंदगी सिर्फ कुछ फिल्में एक्सरे सीटी एमआरआई के देखने में बीत जाएगा, ऐसा नहीं है. It is not a life of just black and white. It is a life of colors in which not only you can become a good guy who is into diagnosis, you can be a therapeutic person as well. You can satisfy your your society center of doing some surgical interventions as well. And मेरे को लगता है जिस हिसाब से इवोल्यूशन हो रहा है आने वाले वक्त में there will be a point of time when radiology will shoot up. It has already shot up, but it will shoot up even more जब इंटरवेंशन का कंपोनेंट धीरे धीरे और बढ़ता जाएगा, बिकॉज द वर्ल्ड विल चूज दैट काइंड ऑफ अ स्पेस वेयर मिनिमली इन्वेजिव ट्रीटमेंट एंड विद मोर प्रिसीजन एंड स्पेसिफिसिटी एंड दैट ओनली रेडियोलॉजिस्ट कैन डू. तो इसका फ्यूचर बहुत अच्छा है. टेलीरेडियोलॉजी एक थोड़ा सा ग्रे जोन में रहता है बिकॉज वो एक कंपटीशन की वजह से जो भी कम्युनिटी में हुआ है, जो डॉक्टर गौरव ने बताया, वो दैट्स ओके. अब जहां तक बात है इसके अंदर पैसे की, सो प्लीज अंडरस्टैंड दैट एज अ फ्रेशर आपका जो 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 आप 25-26 पे निकलते हो तो आप सीधा ऐसे जाते हो. 2.53 लाख आपकी स्टार्टिंग सैलरी. इफ यू गो टू अ टीयर 2 टीयर 3 सिटी यू कैन आस्क फॉर इवन मोर. बट येस, उसके बाद देर इज अ प्लेटू विच इवन डॉक्टर गौरव विल एग्री कि थोड़ा सा एक प्लेटू रहता है. ऐसा नहीं है कि आज आप एक एमआरआई देखने के 5,000 रुपए मांग लोगे, बिकॉज एमआरआई हो ही 7-8 हजार में रहे. सो बट एट द सेम टाइम यू नीड टू अंडरस्टैंड विच ही मेंशन एट द बिगिनिंग दैट द मोस्ट ब्यूटिफुल थिंग इज वर्क लाइफ बैलेंस. जल्दी पैसा है, अच्छा पैसा है, स्टेबल पैसा है, लंबा पैसा है, और इंटरवेंशन के बाद तो फिर पैसा ही पैसा है. ये बात मैंने इसलिए भी करी है क्योंकि हर बार ये सवाल आता है, पैसा पैसा पैसा. तो आज हमें समझ में आ चुका है कि कितना आप इसमें कमा सकते हो, कितना आपका सेटअप का कॉस्ट है. क्या इसके अंदर आपको मिलेगा, एंड दिस इज नो लॉन्गर बीइंग कन्फाइंड टू अ रूम. यू टॉक टू पेशेंट्स, यू ट्रीट देम, यू टॉक टू डॉक्टर्स, सर्जन्स, फिजिशियंस, यू डिस्कस डायग्नोसिस विद देम. और मैं तो ये बोलूंगा, आज की डेट में, इफ यू आस्क मी पर्सनली, मेरे क्लिनिक में जितने पेशेंट मेरे पास आते हैं उसके अंदर अगर 10 पेशेंट आ रहे हैं एक दिन में, तो 5 पेशेंट के अंदर मैं डॉक्टर गौरव के बिना आगे नहीं बढ़ सकता. क्यों? क्योंकि मुझे लगता है कि जब तक ये उस स्कैन को देख के अपने एक्सपर्ट ओपिनियन नहीं देंगे और मैं अपनी ओपिनियन के साथ उसे कोरिलेट नहीं कर लूंगा, तो मैं आगे नहीं बढ़ना चाहूंगा. एंड फॉरगेट अबाउट डायग्नोसिस, मोस्ट ऑफ द टाइम्स ही इज द पर्सन गाइडिंग मी ट्रीटमेंट एज वेल. इन द एंड ऑफ दिस वीडियो आई एम शेयरिंग हिज डिटेल्स एज वेल, जहां पर इनका ईमेल आईडी है. अगर आपको कोई क्वेरी आती है तो आप उन्हें ईमेल भी कर सकते हैं, अपने डाउट पूछ सकते हैं. स्कैन्स रिपोर्ट कराने हैं आप वो भी कर सकते हैं. एंड यू कैन फॉलो हिम ऑन इंस्टाग्राम. मैं इनके जो भी लिंक्स हैं सारे अभी आपको स्क्रीन पे दिख रहे होंगे, और अभी थोड़ी देर बाद और भी वो फ्लैश हो जाएंगे. ही इज एन अमेजिंग गाय. मेरे लिए बहुत बड़ी ब्लेसिंग है, बिकॉज आई मेट हिम एज अ स्टूडेंट, देन आई मेट हिम एज अ रेडियोलॉजिस्ट, देन आई मेट हिम एज अ कलीग, देन आई मेट हिम एज माई ट्रीटिंग डॉक्टर. और आज जो
Fortune
उन्होंने
is all
बताया
mine.
है.
Fortune is all mine.
नहीं
And
नहीं नहीं नहीं, नहीं, नहीं.
I really appreciate that sir has been a guiding light for so many students. एक टाइम था जब मेरे पीजी काउंसलिंग थी 2013-14 टाइम पे, तो हम जाते होते थे पूछने के लिए, कंसल्ट करते थे. एंड वी हैव गॉट ample so much good guidance from all these mentors, and I really thank you sir for that. And आप अभी भी इतने सालों के बाद भी you are still on the same pace with such great enthusiasm. uh,
Yeah.
that is really infectious.
Yeah, at least I'm trying to stay more relevant by keeping in touch with the young people like you. तो मेरी कोशिश यही बरकरार है. चलिए, thank you so much, Dr. Gaurav, and thank you so
Thank
much to all of you who are watching and listening to all of us. Thank you so much. Bye bye.